The patient is a 64-year-old female admitted to acute care with progressive right-sided weakness. All tests were unremarkable, and the patient was diagnosed with left CVA and has a history of diabetes as well. The patient presented with mild dysarthria with fully intelligible speech. The patient is aware and oriented, able to follow complex commands, and shows no signs of neglect or nepraxia. The patient presented with mild right central facial droop, mild right upper extremity spastic hemiparesis, and mild hemiparesis in the right lower extremity also. Per PT eval, the patient's tone was increased in her right upper extremity at a modified Ashworth scale of 1. The limitation activity I chose to focus on was her inability to be independent with transfers due to poor balance and core stability. As a safety concern, one would not want her husband to have to lift her or to provide max or moderate assistance to help her out of bed. That being said, we need to get her as independent as possible in those areas. As her therapist, I would address her core stability prior to gait and transfers until she is first able to transfer safely, preferably with independence, but min assist will be easier on her husband than max assist. Improving her ability to transfer safely will increase her independence and decrease the risk of further injury to her, and to hopefully avoid her husband getting injured by wanting to help transfer her. Poor core strength and spasticity in the right upper extremity are the impairments in body structure and function that I will be addressing. I chose decreased core strength and spasticity over other impairments because stability needs to come prior to mobility, and this will increase the patient and her husband's safety and hopefully prevent further injuries during any transfers. Combined with decreased strength and coordination in the right upper extremity, the poor core strength, if not addressed, could lead to the patient requiring assisted care, lengthening her recovery time, and prolonging her stay at the hospital. I will address the patient's core strength while she lays supine, keeping her pelvis and spine neutral by having her knees bent. I plan to use her left upper extremity to perform D2 PNF. I will begin with rhythmic initiation and then provide resistance using dynamic reversals. The patient will have to engage her core throughout to meet my resistance through her full range of motion. Hopefully, she will tolerate this for 10 reps at max resistance. I chose this intervention not only because it addresses strengthening the arm that she will be relying on, but it will trick her into working her core while she is focusing on something else. I chose spasticity in the right upper extremity as my other impairment that will be addressed. If the patient's tone is not decreased and the muscles correctly strengthened, she may not be able to fully be independent with all ADLs and could eventually develop contractures. I will teach her and her husband how applying ice and then stretching and then facilitating joint approximation with weight shifts will help her achieve her goals. The patient will hopefully tolerate supine to sit transfer, followed by approximation of her bilateral upper extremities and lateral weight shifting while sitting edge of bed. It is anticipated that the patient will require tactile cueing and wedges to achieve desired postures and positions. I will give the patient verbal instructions and verbal cueing as needed since she is oriented and able to follow directions. Thank you.